Hi, everyone. We're just waiting for the attendee numbers to stabilize, and we'll get started. All right. Hello, everyone. Thank you for joining and welcome to the May TUSM Global Health Seminar, which is our final seminar for this academic year. I'm Ramnath Subbaram, an associate professor in the Department of Public Health and Community Medicine and the faculty lead for the seminar series. This academic year, we have covered a range of topics, including discussions of novel anti-malarial medications, lessons from Botswana on addressing the HIV and COVID-19 pandemics, the role of African-centered healing circles in addressing mental health, the role of community health workers in sustaining health systems in African countries, the public health impact of the Indian rotavirus vaccine, and quality improvement initiatives aimed at enhancing neonatal survival. This seminar has also historically taken on contemporary and urgent public health crises. For example, 3 years ago, this seminar brought academic experts to discuss India's catastrophic second COVID-19 wave, which resulted in the deaths of an estimated 3 million people over 2 months. With all of our seminars, in the spirit of the university, we aim to foster a space for respectful dialogue and education, even when discussing some of the most challenging issues facing public health, society, and the human condition. We recognize that issues touched upon in today's seminar may be particularly challenging for some people to hear, and we should note as a content warning that this seminar focuses on the health consequences of war, including discussions of violence, famine, and other adversities. In October of last year, the attack by Hamas killed over 1,200 people in Israel and 235 people were taken hostage, many of whom are still being held hostage. These attacks by Hamas were unequivocal violations of human life, human rights, and human dignity. Even as we hope for the safe and unconditional release of remaining hostages, our seminar today focuses on the public health crisis that has emerged in the Gaza Strip as a result of the subsequent Israel-Hamas war. As of 29 April 2024, more than 34,000 people in Gaza had been killed as a result of direct violence, of whom a meaningful proportion are women and children. In addition, this public health crisis is influenced by critical determinants of health beyond violence, including challenges due to displacement of a large proportion of Gaza's population from their homes, reduced access to safe and adequate water, inadequate access to high-quality sanitation, loss of health infrastructure, insufficient access to food, with imminent risk of famine in parts of Gaza. At the start of the seminar, I also want to note that laws or policies may be referenced as these sometimes directly influence public health, including during humanitarian crises. Whenever our speakers refer to laws or policies, these will always be in reference to the actions of governments or non-state organizations, and not in reference to the people who live in a given country or territory. I also want to note that, as with all of our seminars, the speakers' views are their own and do not represent the views of Tufts University, the Tufts University School of Medicine, the Office of Institutional Inclusive Excellence, Tufts Global Health Programs, or the Tufts Center for Global Public Health. We are grateful today that we have 3 academic colleagues who will discuss this public health crisis from an evidence-based perspective. In the interest of time, I will introduce all 3 speakers now. Dr. Karma Hawash Kumaral is an assistant professor of neurology at Harvard Medical School and a pediatric neurologist and epileptologist at Boston Children's Hospital. Originally from Nablus, Palestine, she attended the University of Jordan Medical School. Her work and research focus on studying and treating traumatic brain injuries in children and adolescents at the Brain Injury Center at Boston Children's Hospital. Dr. Kumaral also leads the Health for Palestine Initiative, or H4P, to improve healthcare in Palestinian refugee camps. She is active in mentoring and promoting equitable healthcare. Given that the primary audience for the seminar is in the School of Medicine, Dr. Kumaral is invited for her experience as a clinician who is engaged in direct clinic and public health work aimed at improving health in Palestinian refugee camps. Dr. Yar Amassi, PhD, is an assistant professor at the University of Central Florida in the School of Global Health Management and Informatics and a visiting scholar at the FXB Center for Health and Human Rights at Harvard University, where she is co-director of the Palestine Program for Health and Human Rights. She is also a non-resident fellow at the Arab Center in Washington, D.C., and Democracy for the Arab World Now, DAWN, as well as a 2020 and 2021 Fulbright United States Scholar to the West Bank, and a 2023 Palestine Fellow for the Foundation for Middle East Peace. She also previously served as the U.S. Fellow for the Al-Shabaka Palestinian Policy Network. Her research focuses on global health, human rights, and development in fragile populations. Dr. Assi has written for the New York Times, the Washington Post, The Guardian, and The Nation, among other publications, and has been featured on Al Jazeera, BBC, The World, and other outlets. Her book with Johns Hopkins University Press, called How War Kills, The Overlooked Threats to Our Health, examines war as a public health crisis. In addition to her expertise on the health consequences of war, Dr. Essie has been invited to speak based on her research on structural determinants of Palestinian health, and more recently, geospatial analyses of infrastructure that is vital to health in Gaza. Our third speaker, Dr. Alex DeWall-DeFil, is Executive Director of the World Peace Foundation and Research Professor at the Fletcher School here at Tufts University. He has worked on Sudan and the Horn of Africa since the 1980s as a researcher and practitioner, focusing on humanitarian aid, human rights, and conflict resolution. Professor DeWall's recent books include Mass Starvation, The History and Future of Famine, published by Polity in 2018, and as a co-authored book, Sudan's Unfinished Democracy, The Promise and Betrayal of a People's Revolution, published by Hearst in 2022. Dr. DeWall has been invited to speak today, given his leading global expertise on famine, which is a concern in Gaza today. A note to the audience, we will hold questions until the end of the three presentations. Though for the online audience, questions can be asked as they arise using the Q&A function on Zoom. And we will have about 10 minutes or so of Q&A after the three presentations are done. I now invite Dr. Komarel to present her talk.
Thank you so much, Dr. Sabarama, for inviting me, and I'm happy to be here amongst you. I did my residency at Tufts Medical Center, and I have very fond memories of my time there. I'm honored to be speaking today, and if you allow me to share my screen, I will start my talk. 1 second.
Sorry, 1 second.
You can share.
Yeah, hold on. Can you see my screen?
Yes, you're good. We can see it.
All right.
But it's not in presenter mode. There it goes.
Okay. So I'm a clinical pediatric neurologist. My work is focused on seeing patients clinically. And I started working with the Global Health Department at my hospital, Boston Children's Hospital, about 3-4 years ago. And I have always been guided by the work of Dr. Paul Farmer, who started Health Partners in Health, who really put a stamp on global health. Just starting with a quote, "Medicine should be viewed as social justice work in a world that is so sick and so riven by inequities." When I started thinking about global health and how to approach it clinically, I discovered that the WHO definition of health applies now as it applied in 1946. Health is a state of complete physical, mental, social well-being, and not merely the absence of disease of infirmity. And global health had some origins with WHO in 1978 with the start of the program Health for All. Health for All was focused on international health. The goal was universal health coverage year 2000. We are year 2024, and I don't think we're anywhere close to universal health coverage. However, it is still a goal for many people. Health for All was ratified by 160 WHO member countries, and it really marked the beginning of our thinking about global health movement that is focused on justice, equity, focused on delivery of medicine in a way that is effective and that is accessible to all population. The focus is disease prevention rather than curative medicine, and as we all know, preventative medicine is a much more effective, much more equitable way of approaching medical diseases. Global health is influenced by many factors that are beyond our hands as medical doctors and medical professionals. Politics play a role, economic status, social status, cultural norms, environmental factors, behavioral factors of a certain community, in addition to genetics. When I started with global health, I was fortunate to work with my colleagues in Health for Palestine. And Health for Palestine means a lot to me being Palestinian and being from Nablus. So I worked in refugee camps both in Bethlehem and Nablus. And the Health for Palestine mission is to provide equity for Palestinian refugees in Palestinian refugee camps. Health for Palestine addresses health problems through the accompaniment model that is classic of many global health movements, including Partners in Health and including how Dr. Farmer approached this. The training is offered to community health workers in the refugee camps to give them the opportunity to become champions in their communities, providing medical visits and providing physical support, even if they are not medically trained. And their training happens through interaction with medical providers who have more expertise or less expertise, depending on how the interaction happens. It is from the grounds up and it's not enforced from top bottom. So the value is placed on community members and their input and the way they like to approach tackling healthcare in their own communities. We focused initially on hypertension and diabetes, and when I joined, we started focusing on well child visits and education about nutrition and development. In Balata, we have over 9 community health workers with 145 cases that are being followed on regular basis. There has been discovery of many undiagnosed medical conditions through the visits with the healthcare workers. Psychological support offered by the healthcare workers in the refugee camps definitely led to improved mental health conditions. Some patients who suffered from depression and they were not even able to leave their homes because of their deep mental health issues have started opening up and becoming more engaged in their communities by virtue of giving them weekly and sometimes daily daily visits by our dedicated healthcare workers for Palestine, healthcare workers in the refugee camps. Some findings have been published in this article that focused on diabetes and hypertension, and briefly I will tell you about it. There have been 2 groups, one group that has received the intervention of the community healthcare workers and one group did not. Both of these groups were very similar in how controlled hypertension and diabetes is. And after 1 year of healthcare worker intervention, we found that there has been a massive improvement in the control of both diabetes and hypertension, which proved to us that this model works extremely well in the Palestinian refugee camps. We are fortunate that the healthcare workers are eager to learn, they are very well educated, and they are very dedicated to their tasks and their craft, and they are very curious. And many of us who work with healthcare workers know that engagement is key for retaining healthcare workers and for making them more effective in their community. I'm just going to share some photographs of how casual the exam is. This is one of our colleagues who goes regularly to the refugee camps, and this is the sibling of one of the school children. And the intervention is very, as it goes, it's not very formal. And this is a classroom where moms learn about early development and well child visits. This is an example of the accompaniment model. This is a gentleman who is in his house and the healthcare workers comes to his house, measures his measures his blood pressure, measures his glucose, and provides guidance on how to take medications and exercise and diet and all these things. This is me, I'm one of the healthcare workers here. And I just wanted to shift my attention to Gaza, because when Gaza happened, we all wanted to be able to help. And it was very extreme. The extreme decimation of the healthcare system has raised significant and substantial challenges, especially for somebody like me who's a pediatric neurologist. And I quickly wanted to be involved in providing any kind of help that I am able to. So I signed up for a telemedicine group that is called Gaza Health. And through the telemedicine group, I was able to connect with some patients in Gaza. And if you allow me, I will share some of my experiences as a clinician and highlight the difficulties that we found. This is a message from a physical therapist who posted, how do you do physiotherapy on babies when a 1-year-old who cannot walk lost his legs? And it's an extremely challenging question that I do not think any of us has a good answer to it. By virtue of being a neurologist, a lot of the brain injury cases arrived at my mailbox, where I was asked to contact families with children who sustained brain injury because of the blast injuries. What I found is that most of these children who survive have closed brain injury with some evidence of subarachnoid hemorrhage or subdural hematoma. Some of them have never been treated, and they just sit wherever they are, mostly in the tents, because the population in Gaza has been displaced so many times as a result of the bombardment and as a result of the evacuation orders that have been given to them. You know, as challenging as it can be to take care of patients remotely, it does not even compare to how it feels like to receive a call from a mother telling me that my these two daughters have been in a bombardment site, and there was an explosive injury that did not affect them physically. It was a closed brain injury situation, but both of them had the raccoon eyes, suggestive of subdural hematoma, probably a skull fracture that is subtle, and both of them were in coma for many days. And when they woke up from the coma, they were not the same. And no matter how I tried to be helpful by saying, you know, let's keep them hydrated, let's make sure that they are fed appropriately, control the temperature, it was a very embarrassing situation for me to give recommendations that I know are not possible to be implemented in a situation where the bombardment is happening on daily basis, and the food supply has been cut, and the water supply has been cut, and the water is not even sanitized. Another challenge that I had is the epilepsy patients who quickly ran out of their medications. And I had tens of cases of patients who started seizing. And the question that was raised, what can we do to stop this? And obviously, epilepsy, you need to treat with medical pharmaceutical drugs that are not available, and sometimes they're available. So a lot of the times it was a matter of switching a medicine to whatever is available. And as we all know, switching a seizure medicine from one to another takes a lot of thinking. We need EEG data to make a decision. We need blood levels. We need to find the exact right medicine to each seizure type. And when that is not available, the decision making is completely haphazard and completely random. And basically, we are relying on luck. So I found myself titrating down medications to half the dose to make sure that it lasts for at least a couple of weeks until the medication is available again. I found myself switching from a medicine that was controlling some of the seizures of some of the patients to a medicine that I know is not going to be as effective, but I did not have any choice of making the recommendation no matter what. And this was and continues to be a very difficult situation. I also found that it was very difficult to keep in touch with these patients because they would be displaced and they would lose internet connection. And then 2 weeks later, I might hear from them and hear more of the challenges that have been happening to them in the 2 weeks. So a major emotional and mental stressor for them and for us as a medical community trying to help them. The hospital situation has been extremely challenging, where most of the hospitals in Gaza have been completely evacuated, bombarded, or destroyed. The children in Gaza have also been out of school for over 7 months. And some of the main symptoms that I have been hearing from the mothers of normal children supposedly is the extreme behavioral difficulties, the bedwetting, the aggressive behavior, the demanding to have a normal life, demanding to have food, which is not there. I cannot tell you how so many factors and so many things that we take for granted have been completely out of reach for the families in Gaza as a result of the incessant bombardment and the lack of any periods of quiet to just gather themselves and be able to take care of their children and of themselves. I will stop there and I will turn it, I think, to Yara.
Yeah.
Thank you
Thank
so
you, Dr.
much.
Kumral, and we'll hand it over to Dr. Yara C.
Good afternoon, everybody. It's a pleasure to be here with all of you, and I appreciate the opportunity from Tufts to have this discussion here today. I am coming at this from more of a public health perspective. That is my expertise, and I come from this both as a Palestinian and also someone who has done extensive research on health in fragile and conflict-affected environments, including the West Bank. Unfortunately, I have not been permitted to travel to Gaza, but hope to someday. So I'm going to take a bit of a broader look at what we're seeing today, but I could not begin without acknowledging what today is, which May 15th for Palestinians is when they commemorate what they call Nakba Day, which is a commemoration of, in 1948, the uprooting and the displacement of more than 700,000 Palestinians from their hometowns and villages. And why this remains relevant today is, this is a picture from 1948. Many of these refugees fled throughout the region, many of whom fled actually into what is now considered the Gaza Strip. So when we hear these statistics from Gaza about how 80% are refugees, and we think, well, how is it possible that they're Palestinians and they're in a Palestinian territory and they're still refugees? This is because the UN acknowledges that they are refugees from other villages, and they are not permitted to return. And so many of these refugees have fled throughout the region and, in fact, now throughout the world. And when we see images like this from Gaza, and I believe this was taken in mid-November during one of the main evacuation orders, as you can imagine, it brings up some significant traumatic memories and also concerns about what's to come. When will these people be able to return, if they are at all? And I also want to point, and I know we're talking mostly today about the post-October 7th reality, but this is a photo from a protest held by paramedics in the Gaza Strip in spring of 2023, so before all of this. And if you can read on the ambulances, it says in Arabic, English, and Hebrew. So this is clearly a protest that is meant to go to an international audience. Because of the blockade, the medical equipment is crumbling and does not meet the patient's needs. So Gaza has been under blockade since 2007. After the Gaza Strip was declared a hostile territory, after Hamas gained power a couple of years before that. And so what this led to in Gaza was, a underdeveloped, under-resourced health system, which was captured in countless of reports from various UN agencies, MSF, of course, Oxfam. Basically, every health and humanitarian agency has multiple reports on the deterioration of health in Gaza. And so this was an effort by these paramedics. As you can see there in the background, they're kind of driving around the border while trying to get attention to the systematic threats to health long before what we're seeing today. And so now when we look at this photo, and every time I do a presentation, we're left to think how many of these paramedics are still alive and how many of these ambulances are still functioning. So to be clear about what we're talking about today, the occupied Palestinian territories, occupied since 1967, are two non-geographically linked territories. So while the bulk of our chat today will be about the Gaza Strip, which is here bordered by Israel, the Mediterranean Sea, and Egypt to the south, the Rafah border is here in the southern part between the Egypt-Gaza border. The West Bank is where I'm from, where Karim is from. I'm also from Nablus, and is in a very different situation at the moment, obviously not undergoing active bombardment, but still experiencing a significant increase in military and settler violence that has led to more than 400 killed and recorded instances of many ambulances blocked. There was a famous incident, I believe, in January of Israeli military forces dressing as physicians and nurses to raid a hospital and kill patients in that hospital. And just from my family's recollections in recent weeks and months, it's been a very scary, terrifying time. So if the situation in Gaza was not as bad as it is, I feel like we would really be talking about the deterioration in the West Bank, which is getting some pickup, but obviously, what's happening in Gaza has taken a lot of the attention. And it's not just, 2023, 2024. Of course, Gaza has gone through massive bombardment campaigns in the past. 2008, 2009 was the first, just a year after Gaza was declared hostile territory. 2012, 2014, which until last year was the longest and most deadly, with thousands killed. And then 2021, I believe it was May, shortly after the onset of the pandemic. And so, because of the blockade, much of the infrastructure within the Gaza Strip was never fully rebuilt. And this included hospitals, this included other facilities that we would consider critical for civilian infrastructure. And so, with each round of bombardment, despite significant influxes of aid, many items needed for building, rebuilding, in some cases, medical facilities, including steel, concrete, forms of lumber, pipes, were either restricted or significantly delayed in entering. And so reconstruction efforts take a very, very long time. And that is why the UN just issued a report a few days ago that said it will take more than 10 years to rebuild Gaza. And that is probably very optimistic. We still have probably many years of just clearing environmental hazards and unexploded ordnance before it is even safe for life in these areas. So I don't love to focus on numbers because I feel like that can kind of make situations more abstract and disconnect us from the reality, but they are, of course, important, and we are an evidence-based profession, and so we'll go where the evidence is. So according to UN OCHA, at least 35,000 have been killed. There was a report a few days ago that caused some confusion that led some to believe that the overall death toll was reduced. However, there was a discrepancy between the number of identified people where they had full names, registration numbers, birthdays, etc., and bodies that had entered hospitals but were not yet fully identified. So while the overall death toll remains the same, and there was a report in CNN about this yesterday, according to the UN, the number of identified bodies is around 25,000, which includes almost 8,000 children, 5,000 women, 2,000 elderly, and 10,000 men. So the statistic of about 60 to 70% being women, children, and elderly still stands, whether you're looking at fully identified or the full death toll. And it is still assumed that this is an undercount due to many bodies being missing, trapped under rubble, and simply the collapse of the health sector and the ability to do these counts. OCHA also reports at least 78,000 have been injured. So this can range from minor injuries to shrapnel wounds, burn wounds, amputations. Approximately 2 million people have been displaced. There are, according to UNICEF, about 17,000 children who are unaccompanied. Many of these children have been orphaned. They have lost one or both parents. Some are just separated from their families. There are, of course, it's very difficult to get good data out of these conditions, which is something that in global health and public health have to constantly reckon with in these circumstances. So it is likely that we will learn more as we're able to do more retrospective studies. According to CARE and other humanitarian organizations on the ground, there's about 180 women giving birth daily. And because of starvation, lack of sanitation, lack of skilled medical professionals, the reports of miscarriage and stillbirth have increased by about 300%. And of course, anywhere people live, they have a whole other host of health issues, right? So it's not just battle and trauma related injuries. People still have cancer and other health needs that require treatments, pharmaceuticals, interventions, almost none of which are being met at the moment, except for those who've been able to be evacuated. So approximately 2,000 cancer patients, many of whom were receiving treatment either in hospitals in Israel or in East Jerusalem, or in some cases, Egypt or Jordan. Almost all of that has been stopped. About 1,000 people in need of dialysis, 50,000 cardiovascular patients, and about 60,000 diabetics. So the indirect health threats are at this point still incalculable, and we cannot likely know how much excess mortality due to lack of health care there is until we have simply better information and better data on the ground. And so because, that was numbers, and I wanted to touch on the realities of this. These are newborn babies that were at El Shifa Hospital earlier in last fall. These are some of the babies that were fortunate to be evacuated from hospitals in the north to the south. You can see, though, they're obviously not in ideal conditions. They're not in incubators, but these babies fortunately survived. There were reports of several babies who had died in the NICU. The reports of amputations have been among the more hard, I think, for those of us studying this, because many of these amputations are in very young children who will have to, of course, go the rest of their lives with the health ramifications of this. So this, for example, is a baby under the age of 1 who has lost both of, I believe it's a girl, her legs. And there are many, many, many countless reports about amputations, in many cases, amputations that could have been prevented, but because of excess blood loss or infection due to lack of antiseptics and other hygiene measures, an amputation was deemed the best course of action by the clinicians working on the ground. And of course, these clinicians, our colleagues, are people from Gaza, right? So they're also from this environment. They're suffering through this. Many of them have lost family, and yet they're continuing to show up to work every day to try to save as many lives as possible, even with limited resources and challenges. So you can see here procedures being, in some cases, done by the light of cell phones because of lack of electricity, lack of fuel, and because of lack of space in hospitals, especially as now an estimated more than 2/3 of hospitals are completely non-functional. So for patients and for many people sheltering, the hospital is the only place to go. And so the staff working in those facilities is doing their best to try to treat patients in whatever conditions they can. And in some cases, that means just literally on the floor. And outcomes bear out what we're seeing. So for this child, she suffered burns throughout her body. Many organizations, including the Palestinian Children's Relief Fund and Heal Palestine and Med Global and others, had tried to evacuate her because of the closed borders and lack of resources. She unfortunately did not survive. This is a child, a 5-year-old boy who had been amputated, and he was evacuated by this organization, Heal Palestine, and he was actually brought to Boston and received his surgeries and his prosthesis right in Boston. I'm not sure what hospital, but perhaps some of you on this call are involved with some of these patients that are being brought over. in the health system is, of course, not just the buildings, right? So when we talk about destruction, it's not just the hospitals, the medical schools, the clinics, it's people. And people are the backbone of any health system. And this is outdated at this point. This is the most recent infographic I could find on this. But at this point, it's estimated that more than 500 healthcare workers have been killed. And this ranges from paramedics, nurses, midwives, but also deans of medical schools and physicians with extremely high degrees of specialization that are very hard to find in Gaza. So many of those with specializations trained in the Gulf or in Europe, some in North America, and then go back to Gaza for practice. And unfortunately, the loss of people with this level of expertise is not easily replaceable. So this is not just a temporary challenge, but these are generational gaps that will not be filled quickly or easily. And what does that mean when we talk about health system rebuilding and reconstruction? This was the courtyard of Al Shifa Hospital earlier, or I guess I should say late in 2023, after the first raid, but before this recent bombing and raid. And you can see it's not just, so Al Shifa is a huge hospital. It's the biggest hospital in Gaza, and it's almost a whole city block. So they have multiple buildings for different specialties, offices, admin, etc. And what ended up happening was that many people, thinking that this was a safe shelter, came here for shelter. So families would literally pack up and just build tents, lay on blankets outside in the courtyard. A lot of media, so local Palestinian media, sheltered at hospitals. So hospitals became a life-sustaining mechanism in more ways than one. And so the loss of a hospital is quite alarming. So now these are some of the living conditions of those who have evacuated, who've been displaced. They're living in tent cities. Many were in Rafah, who have now either moved to other parts of Rafah or have evacuated entirely because of the most recent invasion. And you can see kind of living conditions that they're facing. So, large families are sharing tents, lack of food, lack of water, lack of places for children to play. As Karima said, children are out of school. There's very little more that can be done except to keep these people sheltered. We had a lot of health concerns in the winter as we were worried about respiratory infections, flu, COVID-19, and others, which we did see. And now as summer approaches, we're extremely concerned about how the heat and humidity will affect those living in these obviously non-air conditioned tents without good ventilation and no other place to go. So we're really concerned about what that might mean as the heat increases. So some of the non-battle related threats to health, obviously, crowded conditions. This is a perfect recipe for infectious disease spread. You have a lot of people crowded into tight areas, really unable to go anywhere, especially in times of bombardment. They feel unsafe to do so. Lack of clean food and water, which I know Alex will touch on. A big concern is lack of access to waste disposal and sanitation services. So we're seeing really high and increased incidence of diarrhea, including bloody diarrhea among children. And we're keeping an eye on some of that infectious disease spread through waste and through animal vectors. Consider all of this in the context of malnourishment and bodies that are simply weakened by either displacement, lack of nutritious food, mental trauma, obviously, lack of access to vaccinations. So even the typically scheduled vaccinations are being highly disrupted. Many children, especially those who have been born in the past 7 months, have probably received no vaccinations. So we saw in rural parts of Syria during the height of their civil war, multiple polio outbreaks that required significant international intervention to stifle. And we're really concerned about seeing these kinds of outbreaks among these populations. For those who do need advanced medical care, there's obviously a lack of not just tools and antiseptics in general, but the ability to clean them and to maintain hygiene between patients. Many doctors report they can't even change gloves between patients because there's such a lack of resources. And for the health services that do exist, most are focusing, as you can imagine, on trauma care because that is the overwhelming need. So if you do have cancer, if you do need dialysis, if your appendix burst, if you have really any other health issue, there is very little resources there for you. So even a lot of the international medical staff that has entered Gaza is focusing on trauma-related care and triage. So we are really fearful of how diseases and chronic diseases and others will develop in this time of basically no access. As a public health person, I could not let you escape without talking about the social determinants of health. Obviously, in terms of economic stability, really no one in Gaza is working, no one is making money. And for the markets and areas that do have food available, the prices have become extremely high. So even if their market does have food, you are not, in many cases, able to afford it. And for many people, their entire livelihood was in their home. They had spent money building their homes. And so now that their homes are destroyed, all of their life capital is gone and they're homeless. So a lot of questions about what that means. In terms of education, we know children are out of school and every university in Gaza has been bombed. I personally have been helping many medical students from Gaza try to find ways to continue their education either in Egypt, in the US, in Europe, because despite having fled and all these circumstances, they still want to be doctors. We talked a lot about health and healthcare. Obviously, the neighborhood and built environment, there's very little of it left. There's entire city blocks that are completely uninhabitable. And the social and community context has also been highly frayed, as you can imagine. And I'll end by talking about a paper that I was recently a part of that was just published in Conflict and Health. It's an open access paper, which means you don't have to pay to access it or go through your library. And this was with an amazing team that includes GIS specialists, international health and law specialists. And this was just a look at the spatial analysis of damage to what we deemed critical civilian infrastructure, which is defined in the paper as water access and distribution points, education, health facilities. And this was just in the first, what we call the first phase of the military campaign. So from October 7th until just a few days before that first week-long ceasefire. And this is just one of the images that we took. So especially in the first phase of the war, most of the bombardment was focused in and around Gaza City, which is in the north. So I just took one image here. So you can see that of these facilities, health, water, and education, a significant amount experienced direct damage. And this was just the first 6 weeks. So we know that if and when we do this study again at passing the 7-month point, this will be much higher and will be spread much more throughout the strip itself because bombing has kind of followed and traveled southward. We're now obviously bombing here in Rafah, which at the time of our analysis had the least amount of bombing and damage to infrastructure. So some of our key findings whereas damage was detected at 60% of all health facilities, over 2/3 of educational facilities, and over 40% of all sites of water infrastructure. In this phase of the military campaign, the majority of damage was in the north. So especially Gaza City, that's where Al-Shifa is, and that's where it was basically the main city of the Gaza Strip. So while some people had evacuated, many hadn't. If you may remember earlier in this campaign, Israel instituted a mandatory evacuation order for the north, which the World Health Organization deemed a death sentence for patients who were immobile or could not be moved from their beds. And our analysis also found that the evacuation corridor itself suffered damage, infrastructure damage, both direct and indirect. And this is in line with reports from people who had fled on that evacuation route that they had either been in proximity of bombing or were directly targeted by snipers. And through spatial analysis, we were able to demonstrate with statistical significance a lack of randomness of clustering around this infrastructure. So if precautions were being made to avoid this infrastructure, we would expect to not see this statistically significant relationship. And I'm happy to talk more about the study in the Q&A. And I will end now and pass to Alex. So thank you so much.
Thank you, Dr. Assi. I now pass it over to Professor DeWall to speak.
So thank you, Ram. Thank you, Karama. Thank you, Yara. And thank you for organizing this very important and timely seminar workshop. And it's a regrettable privilege to share what is now 40 years of academic professional experience on famine, a topic that I'd hoped would be only of historic interest, but sadly is not the case. And I described a couple of months ago, the food emergency in Gaza as the most intense since World War II. And let me explain why. So food emergencies are measured along 3 dimensions. There's magnitude, the total numbers affected and the numbers who die. And Sudan is currently the world leader in that particular terrible league of deprivation. There's duration, how long the suffering goes on, and Somalia, South Sudan, and Yemen are competing for the top spot there. And then there's intensity, how severe is the deprivation of food and other essentials, how severe the malnutrition, how high the child mortality in a particular location. And Gaza here is really off the charts. And it's also unprecedented in modern history in the speed with which a population that previously had very low rates of malnutrition has been reduced to famine conditions. And I would argue this is a famine by any metric. 1 million people are by now estimated to be in phase 5 catastrophe, the worst stage of the metrics of the Integrated Food Security Phase Classification, the IPC, the system developed some 20 years ago for measuring food crises. And the US government's own famine early warning system, FuseNet, concurs. So let me just give a few comparisons here. So the first is the numbers of humanitarians and health workers who have perished. So according to the Aid Worker Security Database, in 2022, 116 aid workers were killed worldwide in the course of their duties, in airstrikes, shelling, shooting, kidnapping, landmines, etc. The most dangerous country for aid workers in 2022, as it had been for several years, was South Sudan, which had 23 deaths of aid workers in those 12 months. In Gaza, it's 240 over 7 months and 8 days, plus, as Yara mentioned, just over 500 health workers reported killed and 309 reported arrested. The threshold for defining famine includes global acute malnutrition rates among children under 5 of 30% or more. And that's rare, it's very rare. It's found in northern Gaza. It's found today in Zamzam, a camp for displaced people in Darfur, Sudan. But just to give you an indication of how rare that is, of 177 nutritional surveys conducted during food emergencies and famines in Somalia and South Sudan during the years 2014 to 2018, when those food crises were at their recent worst, there were just 8 cases that had global acute malnutrition of 30% or higher. So in March, the Famine Review Committee of the IPC published a report with a scenario without precedent for acute food emergency descending into famine. Of the 2.2 million people in Gaza, 95% were classified as being in crisis, emergency, or catastrophe, a situation never before seen in the 20 years of the IPC. At that time, 677 were in IPC Phase 5 catastrophe, on the brink of famine, a number that they sadly, confidently predicted would be about 1 million sometime around now, May or June. And by way of comparison, the largest number estimated to be in IPC 5 since the IPC system began was Somalia 2011. And that number was 490,000, so less than in Gaza 2 months ago. I might add that about 255,000 people died in that famine. And IPC level 5 typically implies excess deaths of 2 per 10,000 per day. IPC level 4, which is almost all of the remainder in Gaza, has a level of about half that. So simple arithmetic implies that we may be seeing several thousand deaths from malnutrition and associated causes every month at the moment. Now, even if there were to be an immediate ceasefire and a massive increase in food supply, this wouldn't end this crisis, tragically. So the high-level international pressure for stepped-up humanitarian action has focused on pushing for larger quantities of food by land, sea, or air. And while this is important and necessary, it's insufficient. There are a couple of reasons for this. One reason is that the level of destruction of essential infrastructure, especially water and sanitation, as Yara has been describing, means that communicable disease is on the rise. Families are cooking in dirty water. Sanitation is poor to non-existent. And the IPC actually very specifically warned about this problem back in March. A second reason is that severely malnourished children require specialized therapeutic feeding. It's just not good enough to give them more flour. Children with severe wasting risk organ failure, immune compromise, and there are serious dangers associated with improperly administered nutrition, the refeeding syndrome, which can be fatal. Specialist supplies, including ready-to-use therapeutic food, lipid-based nutritional supplements, micronutrient, etc., are needed, and trained staff are needed for diagnosing, administering, and monitoring treatment. And because pre-war malnutrition rates in Gaza were very low, about 1% or less, Palestinian health workers, however skilled they may be, need training in this particular set of skills, as well as the support infrastructure. And these kinds of advanced nutritional treatment cannot be provided from the back of an aid truck that makes occasional, hard-to-schedule visits. Still less can they be dropped from an aircraft. What's needed is UNICEF and UNRWA working together in partnership. And for all the wonderful work that the World Central Kitchen was trying to do, it cannot substitute for the expertise of those agencies. Now, all 20th and 21st century famines are man-made, gendered language deliberate. The question is, what kind of political and military actions cause them? Some famines are engineered for profit, some for conquest, for consolidation of empire, some to subjugate or destroy an undesired constituency. Most contemporary famines are the outcome of the pursuit of political military objectives with disregard for human life. These are starvation crimes committed with what a lawyer would call oblique intent. The action is deliberate, but the desired end state of the military commander, let us say, is something other than famine. For example, he may want an enemy to surrender. But famine or starvation is the predictable, foreseeable outcome in the normal course of events. A small minority of historic famines have been committed with the intention to exterminate a population. Now, the International Court of Justice, as we know, is hearing a case brought by South Africa against Israel on the claim that Israel is committing genocide against the Palestinians of Gaza. The court will take years to decide this case, and the threshold for proving genocide at the ICJ is extremely high. Now, but regardless of the merits of the genocide claim, the court has nonetheless issued immediate provisional orders to Israel. So the judges on the court are not going to say, because we're not sure if it's genocide, you're still permissible. It is still permissible for you to commit other crimes. They're going to say, stop commissioning those crimes. Now, the most significant order was issued on the 28th of March. And the court cited, and I quote, the spread of famine and starvation, and demanded that Israel should, and I'm going to quote this, and I'm going to emphasize the words, which in legal terms carry great weight. So Israel was instructed by the highest court in the world, and as I should say, as executive director of the World Peace Foundation, one of my predecessors in 1945 drafted the statute of this court. This is a court which our foundation has for 114 years been championing, including, as I said, helping to draft its statute. And what the court ordered was to take all necessary and effective, keyword effective, measures to ensure without delay in full coordination with the United Nations, the unhindered provision at scale by all concerned of urgently needed basic services and humanitarian assistance, including food, water, electricity, fuel, shelter, clothing, hygiene and sanitation requirements, as well as medical supplies and medical care to Palestinians throughout Gaza. Now, Israel nominated a judge to sit on that court, and the Netanyahu government nominated Justice Aharon Barak, former president of the Supreme Court of Israel. He voted in favor of this. He voted for that measure, making that decision unanimous. He explained in his separate opinion that he was voting with his humanitarian conscience and in recognition of, I quote, Israel's obligations under international humanitarian law. Judge Barak did not vote with the majority on a closely related provision, which makes Israel's compliance with this instruction a matter of complying with the Genocide Convention. Just to clarify, he said he was voting with his humanitarian conscience and because of international humanitarian law, which is binding, which is very strong. He just said the Genocide Convention has no bearing on this. Now, the relevant provision of the Genocide Convention is Article 2C, which prohibits, and I quote, deliberately inflicting on the group conditions of life calculated to bring about its physical destruction in whole or in part. And in his dissenting opinion, Judge Barak wrote, the court fails to explain why the provision of basic services and humanitarian assistance is linked to any of the rights found to be plausible under the Genocide Convention. Now, the other 14 judges voted the other way. They disagreed with Justice Barak, and some of them actually dissented from the consensus opinion. They demanded even stronger measures. I agree with that majority opinion. And in my 2018 book, Mass Starvation, The History and Future of Famine, I coined a term which I called counter-humanitarianism. Counter-humanitarianism. The context of this coinage was addressing the question of why famines persisted in the contemporary world, despite the fact that all the material preconditions for abolishing famine were in place. The reason why famines continued was that all contemporary famines are what I called atrocity famines, a term I think is self-explanatory. Atrocity famines come about through the commission of starvation crimes, the war crime of starvation, the war crime of extermination through starvation, or genocidal starvation, compounded by the obstruction of humanitarian relief. Now, that obstruction of humanitarian relief could occur through indifference to human life, through the reckless pursuit of a military objective with no regard for its humanitarian consequences, or through determination to kill through starvation. And counter-humanitarianism referred to that last, a principled denial of essential relief to a starving population. And at the time that book was published, 2018, I struggled to find clear instances. ISIS in Syria was one of the few, but I had the intuition that it might lurk elsewhere. So I included that term in my book for an as yet unrealized phenomenon. And regrettably, that intuition has been borne out. So for the most part, I would class Israel's acts in Gaza in the category of starvation crimes that are the reckless pursuit of military political goals without regard to humanitarian consequence. But I have three provisos to this. First proviso is that Gaza is unlike any other situation of food emergency that I have studied over the last 40 years because of the degree of control exercised by Israel. In 2007, after Hamas took control of Gaza, Israel drew up a plan for the strict control of all commodities flowing into Gaza. Yara has already mentioned this. The document is very interesting to read. It's entitled Food Consumption in the Gaza Strip, the Red Lines. It was intended to ensure that exactly the minimum nutrition was allowed in to prevent malnutrition. It determined a calorie count of 2,279 calories per person per day, slightly more for adult men, slightly less for children, etc. There are 25 detailed pages of charts, tables, and calculations in this document. And as observed by a senior government advisor, the intent was, and I quote, to put Palestinians on a diet, not to starve them. But by implication, anything less than those amounts detailed would cross the red line. It would cross the line into unlawful starvation, that is, unlawful deprivation of objects indispensable to survival. So the recklessness issue in the Israeli case has to be modulated because of the degree of control of Israel. In other cases of man-made famine, there's a degree of uncertainty. Those inflicting starvation in Sudan or in Ethiopia or in Nigeria or in Yemen may not be sure of what other resources the afflicted people can call upon, like remittances or wild foods or reserves from previous harvests. Not so Gaza. The second proviso is that starvation is unlike other war crimes or other violations of international humanitarian law because it unfolds relatively slowly. Clear warnings can be given and must be heeded. And humanitarian agencies, FuseNet, the US government's own system, and the IPC's Famine Review Committee warned from December onwards that Gaza was on a trajectory to mass starvation unless the policy changed. Israel's policy did not substantively change. And that failure to heed the warning introduces an additional element, I would argue, of culpability. And third, and this doesn't apply across the board, it applies to one specific group within Israel. We have never before witnessed the deliberate despoilation at scale of essential humanitarian aid with the express intent of causing starvation. Israeli vigilante groups are doing this, and the Israeli authorities are not stopping. So there is this one group that I would argue is a paradigmatic case of counter-humanitarianism in operation today. Now, Aryeh Naya, who was my boss at Human Rights Watch in the late 1980s, early 1990s, and who is one of the great figures of the human rights movement, just published a column in the New York Review of Books. It will be out in print in a couple of weeks. His organization and he himself personally very rarely used the word genocide. They did so for Saddam Hussein's destruction of the Kurds and for Rwanda. Aryeh described the armed conflict in Gaza since October 7th as one in which both Hamas and Israel have committed violations of international humanitarian law. And for 6 months, Aryeh rejected the categorization of what was happening in Gaza as genocide. Now he's changed his mind. And he writes, I am now persuaded that Israel is engaged in genocide against Palestinians in Gaza. What has changed my mind is its sustained policy of obstructing the movement of humanitarian assistance into the territory. So let me finish on that point, which is, I think, an undisputable clarion call from one of the great human rights authorities of our age. Starvation in Gaza must end. Thank you.
All right. Thanks to all our speakers. I'm going to take some questions, and I'll curate a number of questions from the chat that sort of are cross-cutting. I think I'll divide them right now into sort of 3 categories. One is around statistics and how we measure and how we know what's going on. The second is around responsibility. And so let me just sort of divide it into those 2 categories. The first, and I think I'll put this in to whoever would like to address it among our colleagues. One is about, where do the numbers come from, about deaths, about combatant deaths. This includes, I think, Dr. C, you sort of mentioned the revised United Nations statistics, but in times of war and combat, getting information is very hard. Reliability of information is very hard. There are questions about where this information is coming from. And I would maybe extend that, Professor DeWall, to the IPC measures and how we know what's going on there. And, what's the reliability of the information? How do we sort of adjudicate that information? I'll start there, and then I'll move on to sort of the subset of questions around responsibility.
Shall I jump in with the IPC measures?
Yes,
I mean,
and then maybe others.
Yeah, I mean, I would say that the IPC is very accustomed to working with a whole host of different measurements. And in fact, the word integrated in IPC refers to the integration of all sorts of different forms of information. And I think what is, and so there's years of experience that goes into this type of analysis. And what I find particularly compelling is that we have these two parallel systems, the IPC and FuseNet, which use different methods. And they tend to come, in most situations, to slightly different conclusions. In this case, they converged on exactly the same conclusion. And I don't think you will find anyone in the humanitarian community who disputes this. And indeed, I've not seen any serious challenge to the figures and the methodologies from the government of Israel, other than just kicking up a bit of dust. So I fear we can be deeply, distressingly confident in the humanitarian numbers.
Yeah, I just want to add, as someone who has studied this across contexts, it's always difficult to get numbers out of these situations for various reasons. Of course, in very dire circumstances, simply logistically, reporting is difficult. I mean, we even have problems getting accurate statistics on health outcomes in rural parts of the United States, the most advanced country in history. And so I think we should be clear about that. Numbers will change as better data gets out, and that is what science is. It's constant refining of as we get closer and closer to the truth using evidence. I think with regard to numbers from Gaza, in terms of, especially of the death toll, the US has used these numbers, including in Senate hearings. Netanyahu used similar numbers in hearings to the US Congress as well. Looking at the 4 past military campaigns, the numbers released by the Palestinian Ministry of Health were within several hundreds, in some cases less, some cases more than numbers released internally by the US State Department and others. These numbers were never disputed. And I recognize now that some of that, because the numbers are so large and because some, especially early on, including have called question to these numbers, including the President of the United States. The evidence that we have thus far suggests that these numbers are highly accurate. And if evidence comes out in the future that suggests this is untrue, then we will use those numbers. But all evidence suggests that these are probably undercounts that will grow as time goes on, especially since, as we're talking, we are still in active combat.
Dr. Kumaro?
Yeah, I find the question about the reliability of number when we see the data coming from our colleagues and the people that we know in Gaza, questioning the numbers or questioning the severity of the atrocity is really not doing justice to the amount of suffering that the Palestinian people in Gaza are experiencing right now. And, the motivation behind it is to deny the suffering of a people is, I don't think it's appropriate when we are discussing such a massive disaster that is man-made. So I just wanted to comment on this.
Thank you. There's a second cluster of questions, and I'm going to kind of summarize a few points across these questions. And I think they would go to various colleagues here. And a lot of these go to the question of responsibility. And I think, Professor DeWall, you raised sort of, and again, when we talk about responsibility, they're about state or non-state actors, that is governments or non-governmental organizations, right? That's what we're talking about. We're not talking about people or individuals within countries or populations. But obviously, this is public health in the midst of a crisis. And so some of the questions raised relate to Hamas and what Hamas's role is and what Hamas's responsibility is. And I'll kind of summarize across a few of these dimensions that were raised. One was sort of about the sort of pre-October era, and what the role is of Hamas, which served, sort of as a quasi-governmental entity in the time period before October, in terms of creating the infrastructure, enabling the infrastructure, facilitating thriving of the infrastructure, for example, medical infrastructure, and whether that was enough for the subsequent conditions. The second set of questions, I think, pertains to responsibility after October, which relates to the location of combatants and the sort of non-random location, whether they could be close to critical infrastructure, and therefore, for example, Dr. C, in your paper, whether that association is partly related to that, or the sort of underlying sort of military infrastructure, such as tunnels. So these are sort of the two clusters of questions, just to summarize a few questions that came in and to hear from colleagues who would like to respond to from our speakers.
So I can respond to just a couple of the post-October October 7th issues. Just as a matter of law, the fact that there are combatants in a civilian facility such as a hospital does not remove the civilian nature of that facility. It is a violation of international humanitarian law to station combatants who are active combatants, other than those who are hors de combat, who have been wounded or whatever. It is a violation to station them there, and I have absolutely no doubt that Hamas is responsible for a whole lot of violations. Every lawyer familiar with the laws of war thinks that the level of force used against those protected civilian facilities is wholly disproportionate. The level of force used by Israel is wholly disproportionate. I would say Hamas is not innocent by any means, and I don't want to get into the whole politics of this, but just to stick to the legal facts, and the violations by one side in a conflict never justify violations by the other side. Those are the key points I would make. The other point I would make, as somebody who's actually in my professional career drafted a number of ceasefire documents in different conflicts around the world. A ceasefire has two sides. Those who call for a ceasefire are, if that is to be enacted, calling for both sides to ceasefire. And a ceasefire requires, a ceasefire document, would require things like release of hostages as part of a ceasefire. It puzzles me why the call for a ceasefire has been interpreted in such a hostile way by some on the Israeli side.
Yeah, I completely agree with Alex, and I just wish to add that internationally recognized still is that Israel remains the occupying power of the West Bank and Gaza Strip, even after the pullout of the settlers in the Gaza Strip in the early 2000s. This is not my opinion. This is accepted international consensus by basically any international entity that you can think of. And so ultimately, the responsibility lies with the occupying power. Now, the Oslo Accords established the Palestinian Authority, but the Palestinian Authority does not have effective control over its territory, does not control its borders, is not permitted to build port, is not permitted to do things that we would assume a sovereign state has. And so despite the many, and I want to emphasize, going off of what Alex said, this is why we require independent investigations to be held in the Gaza Strip, because thus far, the external investigations that have been held by primarily media organizations like the New York Times have not confirmed what Israelis claim about many of the health facilities that they have bombed, including that there was this significant command and control center under al-Shifa that would justify it being raided, besieged, and having its staff detained. And so let's allow international investigators into Gaza, and let us, for all who have committed war crimes, and this is not a one-sided call, let us get the facts. And so Israel needs to allow those investigations to happen so we can get to the bottom of what is where and who is responsible.
Dr. Komarel, do you have a response, or should I move on to other questions?
Yeah, I mean, my response is very much in line with Yara and Alex. It is right now the party that has the opportunity to and the cover to exert, and the most damage is one party, and it's the Israeli government that is bombarding the population, civilian and not civilian, hospitals, universities, schools. And that's where we should be able to exert influence, to exert pressure to stop this. Hamas obviously is there, and we do not know where their whereabouts or what they are doing, but they neither have opportunity, neither cover, neither capacity to do harm. And we are now concerned about the civilian population that is starved, bombarded, and killed with massive force in an unprecedented degree. And as a medical doctor, I feel that we are obligated to speak up against this atrocities because we care about civilians, and we care about patients, and we care about children, and we care about their mothers, and we care about lifestyle and their life, and we care about equity and justice. So for some of the audience who are asking about what to do in the medical community, I really think that we should be able to advocate for health for the people who are affected, the civilian people, whether they are Israeli, whether they are Palestinians, whether they are in Gaza, whether they are anywhere in the world. But right now, the Gaza children and the Gaza civilians are the ones who are suffering the most, and we should harness our compassion and our resources to improve the situation and stop this massive killing and massive starvation.
So that touches on the next sort of cluster of questions that I wanted to ask about, which was, what is it that the medical community can do? What is it that the public health community can do? Knowing that this is a public health crisis that is complex, that it is, we are very far away from it. How do we, as here, address some of the public health consequences that are going on? And maybe we'll come back to you, Dr. Komarel, since you just sort of you started us off in that direction, and we'll circle back to you from the physician side.
I'll just briefly say, I think a great step is allowing conversations like this to occur at universities, and offering perspectives and having multiple kinds of events that touch on multiple aspects of issues. Obviously, no single event can cover everything and all the harms that are done to everybody. I think allowing space for conversations I've heard from a lot of student groups in the past many months that have simply just want to talk about it and see what the dynamics are, and maybe don't fully understand the issues. And I think coming from, public health medicine, we are seen, I think, as particularly credible. We are seen as relying on evidence for our conclusions. And I think then that gives us a particular obligation to both look into that evidence and the sources of evidence, but then also use that evidence to advocate for harmed populations. And this is not something that is one-sided by any means. And so I think, obviously there's there's things that range from tangible to less tangible. So obviously there are many Western health professionals that are literally getting on planes, partnering with aid organizations to go into Gaza and offer care. There was just a report the other day about several dozen of these staff that are trapped in Gaza at the moment and are themselves experiencing hunger and dehydration. So we're seeing health risks even to that aspect of this. There is advocating within our institutions, within our associations and organizations that we may be active in. There is, of course, the most or the least satisfying answer when I talk to American audiences, which is to reach out to your congresspeople, to your senators, let them know that you see this as a priority, that you see the civilian suffering and you would like something to be done about that. But I think right now we're at a point where if we can just have honest conversations about what we're all witnessing on a day-to-day basis, and move forward from there, because sometimes we can't even agree on what is being discussed and who has the right to say what. And so I think we can start there.
Professor DeWall, before I ask you to address this question, there's one dimension of this that was also asked in the chat, specifically with regard to nutrition, which is about sort of, as you alluded to, sort of longer-term food insecurity. And what are steps to rebuild the nutritional health of the entire population? How do we tend to those who have been malnourished for a more prolonged period of time, and especially children during specific growth periods? This might, again, circle back around, Dr. Komarel, to you from a pediatrics point of view. But Professor DeWall, that's another dimension to this sort of what do we as society do, I guess.
So I just want to mention two things here, which can actually kick off perhaps a longer response from the medical colleagues. One is that the impacts of malnutrition on very young children and on unborn children can be lifelong, and in fact even intergenerational. We know from follow-up studies from the Dutch hunger winter of 1944-45 that children who are very young or born at that time were not as tall as their peers, did not perform as well in school, and little girls who became mothers, their children also did not do so well. So we need to look at the very, very long-term consequences of this. The other aspect that we need to look at is trauma. And those who I spent time in Ireland, where there was a great famine in the 1840s, and it wasn't until over 100 years later that the Irish were able to process the trauma of that famine. A famine is not just a lot of people dying; it's going hungry and dying. It's a deep social trauma. It's a deep humiliation of people. And public memory of that can take a very, very long time to surface. The same in Ukraine. It took more than 50 years after Stalin's Holodomor, his forced starvation of the Ukrainian people, for the Ukrainians to begin to process what that meant for them and their society. So we need to look not just at the physical trauma, but also the emotional trauma and the social trauma, which will be with the Palestinian people for a very long time.
Dr. Komarel, can you speak to sort of the pediatric question about adding to sort of what Professor Woodwald said, about children under nutrition? I know obviously you're a pediatric neurologist, but this is part of your sort of underlying training.
Yeah, I mean, there is the rapid refeeding syndrome, which can cause significant medical issues. So, there has to be a lot of expertise in managing famine and putting these children back on their growth charts and back on their nutritional trajectory that where they should be. So it's definitely a place for the medical community to work together. I also, want to put a general comment about our interaction today. So, we are faced with a problem that there is a population that is starved, that is bombarded, that is displaced, and I am in the medical community. So I encourage everybody to stop trying to blame people who are being starved for their fate, and put the responsibility on the international community to actually correct this, make sure that there is no children who are starved, no families who are starved, stop this bombardment, because it's getting out of control right now. There is one party who is doing the bombardment and restricting food. We do not need to, to keep blaming each other. We know what is happening, and we need to correct it. And I encourage everyone in the medical community to reach out to other colleagues and to try to connect with the medical community in Gaza. The medical community in Gaza right now is suffering tremendously because there are hundreds of doctors and medical professionals that have been killed, but we still have contact with the survivors. And I think it is upon us as medical doctors to work together, to support each other, because that is what our moral obligation is, to support each other in safeguarding life. And this is a point where we can all meet and we can all be aligned without feeling that that we're taking sides. When I see patients, I treat them regardless of who they are, regardless of their political affiliation, regardless of their gender, regardless of anything. And I treat them as a human. And I think we in the medical community are trained and are obligated to do the same for anyone who needs us. So I appeal to my colleagues to reach out, to talk, to discuss how we can together work to make this world a better place for everyone.
Well, I thank the speakers for your perspectives. We're right at time. And I want to thank you for taking the time to come here today to talk. And, I think these are challenging circumstances to hear about. I appreciate you communicating this. I thank everyone for attending this Global Health Seminar. Again, this is part of a broader series of seminars that happen throughout the academic year. And this is the sort of last in the seminar series. But I appreciate everyone taking the time to do this. So thank you.
Thank you.
Thank you for having us. Thanks to the audience.
Thank you so much for all the questions too.